I have the pleasure to introduce another star from NYU, Mary Mittelman, who I also met back in the mid-90s when we were working as a satellite center with NYU. And she also went on to bigger and better things. I've been to various medical conferences and gerontology conferences, and there isn't a conference where Mary's name doesn't come up as a way to go in terms of dealing with caregivers and the psychosocial approach to treating people with Alzheimer's and their families. So we're really very privileged to have her. I was looking through the bio sketch here, and of interest I found that she is the founder of the Unforgettables, a chorus for people with dementia with their family members, which rehearses and gives regular concerts in New York City. You can tell us how to book them. And she's also planning to launch a Music Men's Minds Manhattan Band to study the effects of playing an instrument on patients with Alzheimer's disease and related dementias. So that we'll find out how we can book them as well. So Mary, I turn it over to you. Thank you for coming.
So I'm going to talk about the last 30 years of research in about 30 minutes. So I think that that the previous speakers have talked a lot about the burden of care for people with Alzheimer's disease, and the worldwide burden is huge. It's about $818 billion US dollars. Well, that was in 2015. And what's important from the perspective of psychosocial interventions is that about 40% of that total cost of care is informal care cost, meaning the cost of the unpaid caregivers, largely family members of people with dementia. Caregivers provide many hours of care for people with dementia. There are statistics that talk about how many hours a week. They say 22 hours a week. But if anybody has provided care for a family member or friend with dementia, you know that you never forget about him. You're really worried about him or her 24 hours a day. The cost for unpaid care in the United States alone has been estimated at about $232 billion. That's assuming that you value this unpaid care at the cost of the lowest paid caregiver. And that's really a way underestimating the actual cost, because many people are either forced to leave their jobs to reduce the number of hours they work, perhaps miss promotions because they are also acting as caregivers, and they might have made a whole lot more than $12 an hour, but the value of their care and the studies that nevertheless, a huge amount of money, but the value of their care is estimated at the cost of the lowest paid caregiver. So I think we haven't yet really totally appreciated the actual value of the care of unpaid caregivers. So there are many rationales for interventions for family members. One of them is that there is currently no drug. I'll have to fix the slide now that I've heard all these promising things. But still, today, there is no drug, am I wrong, that will reverse or stop the progression of Alzheimer's disease. And as Alzheimer's disease progresses, the well-being of the person with the illness is more and more dependent on family and friends who can care for him or her. Family caregivers are at risk of many illnesses themselves. They're at a very high risk of depression, of stress. They are more likely to have physical illnesses as they are through the caregiving process, even though some studies have shown that they actually enter caregiving more healthy than age-matched controls. They have hard physical indications of the stress of caregiving, like stress hormones and high blood pressure and new heart disease. More than half of them report financial stress, and more than half report family conflict. And there are not too many good studies of the physical and emotional impact of caregiving, but it is clear that the cost of the emotional and physical impact of caregiving in terms of caregiver illnesses is undoubtedly huge. So what made us think that support and counseling would work? When I got to NYU, I had an idea that I was going to do a study of family caregivers because my own family, my mother had dementia and my father was her caregiver, and I saw all the problems of family caregiving through the eyes of the daughter who couldn't possibly provide enough to satisfy my father, and at the same time, he pushed us, my brother and me, apart, and he made our lives quite difficult, and his own quite difficult. So I actually originally wanted to find out if there were any other families like my own. And then I got to NYU in 1985 and found 4 women who at the time were working as volunteers, helping family caregivers while their relatives with dementia were being evaluated at what became the Alzheimer's Disease Research Center. And I thought, oh, wow, I could actually, rather than just study the problem, I could see whether these people had figured out a way to help. And so I sat in a room with them for a couple of hours, and I asked them to please explain to me what they were doing and describe it. And one of the things I said is, well, what do caregivers have in common? Because I want to write a grant proposal to see whether what you're doing is helping. And they said nothing. And they must have said nothing one way or another, on and off through the whole 3 hours. I mean, well, if I don't have a theme, how am I going to study this? And they kept saying, well, caregivers are all different. And so that became the theme of our research, one of the themes anyways, that caregivers are all different. And we really have to individualize how we help them to match their individual needs and the families that are around them. And it was only after we got funded in 1987 to do our first randomized controlled trial, 3 years after that, Leonard Perlin published the stress process model. And this is a very simplified version of what the model says. The model says there are things you can't help. Those are the things on the left-hand side of this slide. The person has dementia, and there are background characteristics, age, gender, ethnicity, that affect how people can provide care and affect the risk of depression and perhaps the risk of nursing home placement of the person with dementia. But he said, he hypothesized that there were 2 things that could actually alter those risks. One was support, and the other was appraisal. So support meaning both formal and informal support from family and friends. And appraisal meant how you understood the symptoms of the person. So my father, for example, he knew for sure that my mother could do better if she tried. He never really grasped the idea that her dementia was not her fault, that she couldn't do anything about it. So instead of being sympathetic, he was angry. And that totally changed the way he was able to interact with her. So those were the 2 hypothesized, what they call mediators, social support and appraisal. And in fact, what we were able to show with our study over the long term was that those were the 2 things that affected our ability to create better outcomes for the person with dementia as well as the caregiver. So the first study that we did, of an intervention which we now call the Nyu Caregiver Intervention, we defined it as a multi-component intervention, including counseling, support, and education. It was individualized to the needs of each family in response to what I learned from those 4 women who were working at the center. It emphasized support for the primary caregiver. And it was available when it included the family caregiver and other family members as well, and that was unique and is unique to the Nyu Caregiver Intervention. We made sure that we were available when needed and as long as needed, and it was geared to the stage of dementia. So dementia changes over time, the symptoms change over time, and we felt it was really important to be available to the family as new symptoms occurred or as there were other life crises that they were living through so that they had someone who they could call and rely on. So the intervention, the way we designed it, it starts with a comprehensive intake assessment and regular follow-up assessments. The follow-up assessments were originally intended to help us get data to to find out whether the intervention was helpful. But in fact, the caregivers told us that they were really glad to come back and have this reassessment so they'd get another chance to talk to the counselor, and they'd get another chance to think about what it was that they might want to change. The first part of the intervention was meant to be conducted in 4 months. It was a scheduled individual and family counseling sessions. First, an individual session, and the main focus of that session was to find out who in the family might be considered to be helpful, could come to family meetings, because we really felt like the family counseling sessions were the most important part of the intervention. And then we had a second individual counseling session. So there were 6 sessions in 4 months. And then we encouraged people to participate in a support group. At the time that this study started, there were already many support groups that were affiliated with the Alzheimer's Association. So we didn't tell them to come back to NYU for the support groups, but rather to go wherever was most convenient for them so that it would be accessible to them. At the time, most of the support groups were weekly, and many of our caregivers participated. And then after a little while, we realized that there was another component to the intervention, which seemed to be very important, which we called Ad-Hoc Counseling. So anyone who had participated as a member of the intervention group, whether it was the primary caregiver or any family member, could call a counselor at any time over the entire course of their participation in the study. And most of the caregivers called very rarely, but almost all the caregivers told us that having the counselor's card with a name and phone number on it made them feel like they had a life preserver that they could use if they really needed it. And so this was not it was a much less expensive part of the intervention than we imagined, but also very effective. So we started out with a randomized control trial. We were first funded in 1987, and those 4 volunteers were then paid staff members. We were funded by the federal government for more than 20 years, and over the first 9.5 years, we enrolled a total of 406 caregivers. And half of them were enrolled in what we called usual care, and the other half got the NYU Caregiver Intervention, including the individual and family counseling. The one thing that that the people who were in the usual care control group never got was the family counseling. And so that is really what distinguished the 2 groups. And what was amazing to me was how many results we got from this study. And I have to say that that was despite the fact that the people in the control group got far more help than we had originally designed the study for. For example, if they would call and say they needed to talk to somebody, they would talk to them first. The counselor would talk to them, and if sometimes they'd even come in with a person with dementia, and they would ask the counselor if they could see them privately. The counselors always said yes, and I always said, "Isn't that person in the control group?" And the counselors always said, "I don't care. It's my job to help people." And so one thing they were not able to do, though, was to have family counseling. And we had an example, before I had analyzed any data, we were asked to be on CBS Eyewitness News, and I went with one of the counselors, Emma, and a person in the study, and she, on television, luckily with me off in the background, on television, on screen, said, "I never would have survived without the counselor." And I'm thinking, this is really bad because this woman's in the control group. And she should be doing badly so I can have results. But she felt like she was really getting a lot of help. And so I was very concerned. But a couple of months later, she placed her husband in a nursing home. And so we had questionnaires for everything. We had a questionnaire about that. And we asked, "Why did you place your husband in a nursing home?" And she said, "Well, my sons never helped me." And the one thing her sons didn't get was they were not part of the family counseling. So we don't know whether her sons didn't help her because she told them that she could do better, she could do fine on her own. A lot of, especially spouse caregivers, and all of these original people in the study were spouses or partners of the person with dementia, will say, "You have your own lives to lead, I can do this." Or they'll say, like my father used to say to me, I need you to come over every day after work, and he didn't. I said to him, but I have 2 kids at home, a husband who can't cook, I'm in graduate school, I can't come over every day. So I wasn't able to satisfy his needs. Or it could have been, and a lot of caregivers say, I don't know why I have to ask, they should know enough to offer. Or the caregiver will offer what you don't want, not what you really need. So all of these issues which were handled in the family counseling session, this lady didn't get. So when we started to analyze the data, we were pleased to see that despite the fact that the control group got more care than was usually available to most people, that the first thing we observed was that we changed the satisfaction with social support of the caregiver. And in particular, we changed the number of people in their social network, largely their family, to whom they felt close. And we increased their satisfaction with emotional support, which I think is at least as important as instrumental assistance. Then we were able to show that as a result of this, we were able to, the people in the treatment group were less depressed than the people in the control group at every follow-up through 3 years, which was as long as we measured that. We were able to show that caregiver stress reaction to the behavior of the person was significantly less, and that started almost immediately and continued for at least 4 years. And that was despite the fact that we did not focus on patient behavior, and the patient's behavior did not, the seriousness of the patient's behavior did not change. It was only the caregiver's reaction to the behavior that changed. We were able to show that we had a significant impact on caregiver physical health. And all of these things were through that one, what we call mediator, which was improvement in social support. We were able to show that these effects lasted through nursing home placement and bereavement, even those outcomes may have occurred as long as 18 years later. And all of these, as I said, all of these outcomes were really driven largely by improvement in social support. I think that was to me, the most interesting finding, that everything else was driven by social support. Then we had the finding that the states and local governments and the federal government thought was wonderful, which was we were able to postpone the time to nursing home placement of people with dementia by an average of 557 days. That's a year and a half. The average length of stay is 3 years. So we were able to basically cut the length of stay in a nursing home by half, and that the difference between the treatment and control group, so the treatment group is in green, the control group is in red, increased over time. And this was, these measurements went on for 12 years. It took us a long time to do this, but luckily we were funded for long enough to show these differences. And I have to say that may be one of the reasons why the NYU Caregiver Intervention has more long-term outcomes findings than any other study, was because we were able to look at people for as long as 18 years. And also because the control group forgot they were in the control group and felt that they were getting really a lot of help, we had less than 5% of people dropping out of the study while the person with dementia was still at home. So this finding about nursing home placement, unlike the findings about caregiver well-being, caught the attention of the federal government, and we started getting funding for additional studies in other states and around the world. But the finding that really made a difference to the government, unfortunately, was something that I was paying much too little attention to, I guess, which was how much money was the government going to save. So colleagues in Minnesota asked me if they could work with me using my data to create a model of how much money the state of Minnesota would save if every caregiver in Minnesota got the NYU Caregiver Intervention. The entire population of Minnesota is 5.5 million people. So that's about half the population of New York City. And they were able to estimate that the state of Minnesota would save $996 million. And that finding, that's net of the cost of home care. So the difference between the cost of nursing home and the cost of home care, if the state paid for it, was still $996 million in 15 years. So what do we do next? That was all great, but I didn't want to stop. So we replicated this randomized control trial in many other places, including the 3-country study that was done in the United States, Australia, and England, and we demonstrated similar findings. We provided the NYU Caregiver Intervention in community settings with Administration on Aging, now part of the Administration on Community Living, in 8 states in the United States. And then we got funding to develop online training. So we were going around the country training people on how to do this intervention. And sometimes that was wonderful, and we even got to go a couple of times. We got sent to other places that were quite wonderful. But then when a couple of social workers quit in Florida, this is what made me think about doing the online training. So we did the training the first time in Florida in March, and that was really neat. I went down there, and before I went to do the training, I went swimming in the ocean. And then they asked us to come back in August because 3 social workers had gotten different jobs, and they wanted us to do the training again, and that wasn't so great. I wasn't eager to go there in August. And also it seemed inefficient for us to be going around everywhere and doing the training in person. So we got a grant to develop online training in the NYU Caregiver Intervention, for which there are other advantages, including you can take the training whenever you want. You don't have to wait for us to show up. And we were also able to standardize it, and we created a certification exam so that you can actually show that you've learned what we've taught. We are right now almost finished enrolling people in a web-enabled version of the intervention so that you can have the intervention without leaving home. Everybody can stay in his or her own apartment if they want, or house, and connect together via video conferencing. And we think this is going to be going to hugely increase the reach of our intervention because many people don't live near a trained counselor or near their family members. And we could even imagine that we could do it in multiple countries where people may have emigrated, for example, from the Dominican Republic, and half the family is here, the other half the family is in the DR, and we could be able to bring everybody together in one living room. So we're looking forward to looking at the data that we're getting from that study to see if we can prove its efficacy the way we proved the efficacy of the NYU Caregiver Intervention in person. We've also demonstrated that it's effective with adult child caregivers. We have many of the same outcomes, including delay of nursing home placement. And we're using the social support paradigm for other interventions. I was really impressed by how important social support, which is such a universal thing that you can do, doesn't require so much training. It just requires a change in how people think about each other. So what was really impressive to me about the social support impact on the other outcomes in the original study was those 6 sessions were in 4 months. But we changed the way people behave towards each other for years afterwards. That's, I think, really impressive. And then the other thing that happened was that because of that $996 million figure, which the then head of the Department of Health of New York State showed to Governor Cuomo, we received funding Cuomo allocated funding for 10 family support programs. They are now available throughout the state of New York. This is the only state in the country that has this kind of family support available. And there are three groups that are providing this support in New York City: Sunnyside, PSS, and NYU. So those randomized controlled trials that I mentioned, there have been more than 1,000 people who've already participated in them. In the new studies, the community translations, and the randomized control trials. But now it's not working. Okay. But we also sort of used the same idea of social support with other interventions for people with dementia with their family caregivers. And the first intervention that was that we did after the NYU Caregiver Intervention was a couples counseling intervention that was funded by a Zenith Award from the Alzheimer's Association. And in this intervention, we also had 6 sessions, but these were 6 sessions with a couple, a person with dementia and with the family caregiver. And in that study, we were able to demonstrate that when the couple were together with a skilled clinician and who treated the two of them as equals, their relationship improved, which was something we were actually measuring, but something we weren't measuring that we found really interesting was that the caregiver, in every one of the cases that we talked to, said that they were amazed at how much the person with dementia, which was their spouse or partner, could still participate. So the person with dementia had been discounting himself and moving away, and the caregiver had been sort of discounting his ability to participate or her ability to participate. And so that looked to us like more disability than they actually had. They were sort of creating what you might call excess disability. In addition to the problems they were having as a result of the dementia, the social situation was creating additional problems. And then, I think connected to this, we were asked by the Museum of Modern Art to evaluate their Meet Me at MoMA program. And that's a program which originally was only there and is now all over the world and in many museums in New York City, where people with dementia, with their family caregivers or paid caregivers, have a museum experience together with a trained educator who takes them to 4 or 5 different artworks, and they talk about the artworks in an interactive way. And this was another example of couples and of a way in which the person with dementia could participate. What was amazing to me was in front of a piece of art, the person with dementia, if invited to comment and talk about it, said really insightful things. And the educator said this was their favorite audience because A, they paid attention, and B, they actually said things that weren't the things they were taught to say in school because maybe they forgot what they were taught to say in school, so they were able to actually interact and see the art in a new and fresh way. And that created a different dynamic between them and the person who was caring for them because he or she saw that the person actually had value. And they told us, I mean, we did have concrete results that were published, but I think that the focus group outcomes were in a way more telling. They told us that in a place where there was no stigma, they felt comfortable talking about and participating, which they didn't in other places. But the other thing that I thought was interesting, and I'm trying to figure out how to do something to study this, was there was one woman in a focus group who was of a Latina background, and her husband was in the late, sort of early middle stage of dementia. And she said she'd never been to a museum before, but her husband was diagnosed at Columbia, and Dr. Bell, Karen Bell, Dr. Bell told me to go to the museum program, so I did it because I do what Dr. Bell says. And she said, I figured that even if I was embarrassed and afraid to go to a museum because I didn't know how to behave, but I thought with people with dementia, I couldn't go wrong. And so she went with her husband, and she loved it, and she told her son, who went to museums regularly, and because of that, the 3 of them, she, her son, and her husband started going to museums together. So there was she was able to participate as a result of this experience, and I think that this improved the quality of life of everybody in the story. And I think that's really what our interventions are about. They're not about medical care, they're about improving quality of life. And so because of this museum experience, and I was asked to talk about it in Washington, and I was asked to talk about it at a time when somebody else was talking about the music and the brain, and she said she wanted me to stand up and lead a section of a canon, and I said no, and she said please, and I said no, and she said, oh, come on. So I agreed to do it, and I'm standing up in front of this huge audience of administrators and researchers and clinicians, and I'm supposed to sing taco salad, taco salad, taco salad, in this Taco Bell's canon that she made up that had 3 parts. And I did feel a little ridiculous till I noticed that everybody in the audience was singing along and smiling and rocking, and I thought, I'm going to start a chorus. this could be even more effective. So, so it was really because of that embarrassing experience standing up on stage and singing that I started the Unforgettables. And the Unforgettables, this was in 2011. We started with 12 couples. There are now 100 people in 2 Unforgettables choruses, one on the east side, one on the west side. We published data to show the significant benefit. I started the Unforgettables for caregivers. I didn't really, the intention was to provide social support for caregivers. There is a video online you can see of the Unforgettables, and you can see that the people with dementia benefit at least as much as the caregivers, and our statistical analysis actually suggested that they benefited more. And so this is just one example of another example of a way in which you can improve quality of life in a situation in which at the moment there's no medicine that can reverse the course of dementia. So then I want to talk briefly about the family support program, in which we've now been privileged to enroll more than 1,100 people. I mean, I think this is to me, this is such a gift that from research we can actually help so many people. And we provide the things that the state requires us to, which is individual counseling and family counseling and ongoing support. But we've also started some really interesting programs on which I'm going to hopefully be able to do some research now that we've started them. And one of the programs is a buddy program in which a person with dementia is matched with a student in one of the schools at NYU. We learned about that program from Darby Morehart at Northwestern, who has been doing that for about 10 years with medical students. And at this point at NYU, we've had, I think, something like 75 student-person with dementia pairs, both in the School of Nursing, in the medical school, and now we have a service learning course down at Washington Square, where students from any school can take the course and be part of the buddy program as well. And we had a lunch for the graduating clinicians on Friday, and I have to say it was one of the most moving things I ever went to. Almost every person with dementia and student buddy for whom they were mentors spoke up and talked about how much the support of each other meant to each of them. I think we should be doing that with larger, if we had more funding, I think we could do that with many more students and it has benefits for everybody. We use the respite requirement of the state grant to do the buddy program because we're providing respite for the family caregivers. But I think we're also providing a very stimulating experience for the students. And what they say is, what I was hoping they would say is that seeing a person in the early stage of dementia in a regular real-life situation made them think very differently about what this illness was. We've also started a place for us, which is an arts-based intervention. We have it in a different place every day of the week. So people come once a week for about 2.5 hours to do both art appreciation and to create art. And it gives them a sense of purpose and gives them a sense that many of the people in this program have created art that you really wouldn't be happy to hang on your wall. We have a photo workshop, and some of the people with dementia have discovered that even if they couldn't do the jobs they did before, they are able to make really interesting photographs, and the person who runs the photo workshop makes photo books for them of their photograph. So, and of course you know that there is no cost to participating in any of these programs. So I think that many of these new interventions probably deserve research of their own to demonstrate their effectiveness. This is a chart like the chart from the slightly different focus because it puts this family support program closer to the middle, but this is a chart of our relationships. But then I wanted to end with some final thoughts. I think that the problem, right now, our focus is on, everyone's focus, and it would be mine if my husband had Alzheimer's disease, is to try to figure out what is the medicine that's going to make him better or stop him from getting worse. And I think that in a situation like dementia, we have to think about it more holistically. We have to think about what else we can do, what can we do to improve quality of life, for the person with dementia and for the family caregivers. I think social support is essential. There's more and more research that shows that loneliness and isolation are very bad for your health, and many caregivers, because they're either afraid to go out with the person with dementia, or it's too much trouble to go out with them, or it's too much trouble or too expensive to leave him with somebody, or too dangerous, or whatever, that they become very isolated. I think that's why we were so successful with the NYU Caregiver Intervention and these other interventions. And I think dementia is only an example, but I think there are many other illnesses in which psychosocial interventions to improve quality of life should be part of the treatment. Thank you.
Thank you for that excellent talk. We have some time for questions, but first I wanted to just ask or give a small reminder about some of these forms that you guys got when you signed in and registered. These are both a part of the funding that is funding this wonderful program here today to monitor how we're doing and to see the impact of our efforts, and also for continuing medical education accreditation. Thank you for that. And just hands up for questions.
Thank you very much. I hope this is written down or on tape somewhere we can show to people at home and in the community. I guess I'm supposed to be up here. Oh, it is. My question is gender-based, and wondering, since women and men are brought up so differently in relating to going to a counselor, seeing a social worker, so that if the primary person in charge is a male, and that there's a team of women around that male, daughters, sisters, friends of the person needing care. Do you have any suggestions that have worked, or that might work for getting through that barrier that says asking for help is in some way admitting weakness, and suggesting going for a session, with a support person or in a support setting is actually a criticism?
Yeah,
Because
I think there are a lot of answers to that question. I mean, I remember when a friend of somebody I knew told her husband that he should talk to me because his mother had dementia. And she is a doctor herself, but she said to her husband, who's a lawyer, that he should talk to me. So he came and talked to me, and I told him a little bit. This was before we had the family support program. I told him a little bit about the kinds of things we do, and he said, I don't need help. I can do this myself. That was the first thing. But, I really couldn't convince him that he should get help. And there are women who also say the same thing. I can like the woman whose sons wouldn't help her. For all I know, she didn't let them in. But what we learned in the family support program was that that you can offer people something for the person with dementia, then perhaps they will then see the need for something for themselves. And just for example, I was introduced to somebody else. If this happens, I know that what the question is. She said to me, "Can I talk to you in private?" And I thought, oh, okay, yeah. She probably wants to talk to me about someone with dementia. And sure enough, she was concerned about her husband. She knew she was going to have to sell her house because she knew that in a year he was going to be in a nursing home. And I said, well, has he had a diagnostic evaluation? She said, well, he's getting one now, but I know for sure, I can tell. And I said, well, we have this family support program. She said, I don't need help. Meanwhile, and she thought none of her friends knew about this, right? So actually, a few hours later, I saw a friend of hers, and she said to me, can I talk to you about Susan? And so I said, sure. And she said, well, I'm really concerned because her husband is behaving in ways that make me think he has dementia. And so her friends weren't able to talk to her because she wasn't able to talk about it. And she also was not willing to come for help. And then I said, well, you know what? We have this buddy program where your husband could be a mentor to a medical student or a nursing student, and it's about 3 hours, and during those 3 hours, you could do something else. And she said, oh, I could do that. So she enrolled him in the buddy program, and then I told her about the photo workshop, and she enrolled him in the photo workshop. So she was bringing him to our center, and then she said, you know what, I really should talk to a counselor. So she then got the help she needed because she was willing to look for help for her husband when she wasn't willing to look for help for herself. And I think that would be true for the man that I had talked to also if we'd had that program then.
Hi, thank you so much for the amazing work that you're doing. So this is not completely related, but so for patients participating in in Alzheimer's clinical research, it's often an increased burden on the caregiver as they have to bring them there, and is therefore an enrollment and a retention barrier. So now that I've heard about the buddy system, that sounds like it could very much work, but are there any other recommendations you have for reducing that burden on the caregiver
Of participating in the
Yes.
study? Well, there was a study years ago called the CEAD study in which an abbreviated version of the NYU Caregiver Intervention was used. And I think that that's an idea. I mean, I think that providing counseling and support for the family caregiver, which he or she would appreciate, is likely to increase retention in the study. As I said, we lost fewer than 5% of the participants in the years that they were in the study. Well, this was a case in which caregivers were participating as in counseling while the person with dementia was participating in the clinical research. And the 3-country study I alluded to was funded by Pfizer originally back in the late 90s. And in that study, everyone was given free Aricept, and half the participants also got the NYU Caregiver Intervention in all 3 countries. And we had a significant impact on the caregivers because all of the people with dementia were getting the same medicine. So the caregivers benefited in addition to whatever the benefit through Aricept. They benefited from participating. I would love to see that kind of multi-component study done again where the caregiver would benefit and therefore be more likely to bring the person back for a clinical trial. Yeah. Does that answer your question? Okay. Thanks.
Thank you. As a caregiver, I find it very difficult sometimes to get my mom out. She's new onset dementia, and was always, before being diagnosed, was always a go-getter. So now when you try to get her out, she gives you this excuse as, oh, I'm not going anywhere. She could be fully dressed. And, okay, we have to go someplace. Oh, I'm not going anywhere. I just changed my mind. Is there a way, as a caregiver, can you just give me some thoughts, some ideas of how to get her out of the house? Because it can be very trying. To the point where I just sit in a corner and just start crying because I don't know what else to do.
Yeah, well, it's rough because it's probably very hard for her. It takes time to get dressed. It takes time to get out. And then where is she going? Does she know?
Yes.
If she were going to someplace she really wanted to go to, like our photo workshop, which do you think she might go?
I got her into different support groups, and one of the support groups that I got was for her to go to was the Memory Center in Park Slope, and she went there twice, and she really liked it there.
Yeah.
And she keeps saying, oh, I need to go back. But no, I can't get her out in the morning to go to the Memory Center. It's so difficult. She would be dressed. She's just not going out the door.
Even though she thinks if she thought
Yes.
she was going to the Memory Center, they have a lot of
Yes.
good programs there.
Yes.
Somebody else have an idea? I'm sort of, yeah, go ahead.
I mean, one suggestion could be faith-based programs. If there are any churches or faith-based programs that may have.
Yeah, I can see that. Have you thought about having someone come to her house, like one of the people who, I don't know if the New York Memory Center does that, have somebody come to her house with some kind of musical or artistic or something that she would enjoy, and then maybe she would be willing to go to the place where that is done afterwards. I don't mean a social work. I mean, like, for example, the art therapist who works with us goes to the person's house and interviews them and talks to them. So now she has a connection. She would have a connection then to that person, and maybe that would make her more interested in coming out.
So we also have some team members who are sitting over on that side right there, Yi-Ting Chen and Isabel McGlure. They would love to talk with you and give you some more pointers, I think maybe individualized. And they have a lot of, I think, bandwidth in helping folks deal with these sorts of issues and can make that personal connection that we're talking about. I think that's vital. Yeah.
My mother was also very proud, very much of a go-getter. When she realized we were doing things for her, she didn't want to do it anymore because she felt like she was, I don't know how she felt, but I thought that she felt she was putting more pressure on us. So it would be a twofer. So I would be like, I'm going here, and let's stop here first, so that it was something for me that I wanted her to come to the grocery store or something, and she would be happy to go to the grocery store, help me pick up. Oh, on the way home, I'm going to stop at this group, and, you know, but it couldn't be, after a while, we had to shift from I'm doing this for you to doing something for me, and then she was more willing to get dressed and get up and go do something. But I think they feel that they're being a burden, and she didn't want to be a burden, because like, if you don't have to go, then I don't kind of have to go. So that's just one idea from personal experience. I'm sorry?
So one I'll give you also as a tip. For me, my client, their family members say because of the emotional ties, they won't do it for the family, but they will do it for strangers. So other people can coax them to do things that family members can't do because of that emotional tie.
Yeah.
So I also want to offer that to you. And as far as what she said about her mother doesn't want to go because people with physical disabilities are there, I find that a lot with, especially the younger people with dementia. If someone has a physical disability, they don't want to participate because I don't have that. So they want to be with other people that are more like them, but without physical disabilities. They don't want to be with people with assisted devices like wheelchairs and walkers and things like that. So what do you suggest? I mean, the programs are mixed, so it's, you know, it's tough, but that makes them, a lot of them retreat and then feel quote unquote old.
I have to say that I don't. I find that I understand the problem, because to some extent, it's what's good is, in some sense, that people can be less inhibited so they can appreciate art more, but they're also less inhibited so they can say something like that, which someone else might think and not be willing to say. So I'm not really sure how to get around that, because if they're open to everybody, I don't know. I think that's a very good question. And again, I would prefer if a clinician would answer that. Does anybody have any suggestions? Well, I think that that's probably undoubtedly true and inspiring, but the person with dementia may not any longer be able to appreciate that. And that's really the question.
So I think we have to wrap up the questions for Dr. Mittelman
Thank you.
and move on to our discussion panel. Thank you so much.